Hey guys, good evening. Am I audible, visible? Hello. I'll be doing it 6:30 regularly because 7:30 looks a little bit of drag. We'll be crossing 9. I don't want to disturb your dinner schedule and everything. Fine. That's why I kind of moved to 6:30. I hope that's good with you guys. If I'm audible and visible, say me a hi, and without any delay, let's dive into FARRE. Hi Allah, I'm good. Hope you're doing good as well. Allah, all these PDF I think you texted me yesterday, it'll be there in the Telegram channel. Fine. Good evening, Sheetal. Good evening, Ipsita. Okay. So let's start with the same routine. So what I'm going to give you is few clinical scenarios which possibly might come in a long answer question. I don't want the diagnosis. I'm sure you know the diagnosis. I'll be wanting the data points, whatever you feel is appropriate in order to arrive to a right diagnosis, right? That's the thing. Like we'll go with scenarios in CVS as well as in lung, which might probably come as a long answer. And then we'll create templates the same way what we saw yesterday for short answers. The funda is same. If the same short answer comes in long answer, elaborate it. If it's in the short answer, write it smaller, right? So this is the first clinical scenario. I just want you to have a quick look and tell me what are the data points which will be useful for you in arriving to a right diagnosis. You can write data or you can write clinical information available, whatever it is, whichever seems good for you. Fine. Good evening, Srimati. Hello, Ashwath. Good evening, Raghavendra. You can write data or you feel, okay, clinical information looks better. That also is fine. Hi, Ash. See you soon next year. Come on, guys. Comment whatever comes to your mind, what you think probably would be the right one. Heavy smoker, anorexia, great. It's the always everyone, right? Halar mass is the most important thing required for me here. Smoking history is important, obviously, right? Always please start with the age if age helps in the diagnosis, right? An elderly person, because elderly person automatically I'm going to think or make the examiner think in terms of a neoplasia, right? Elderly person, like you said, there is a smoking history, and like you said, the CT scan shows an hilar mass, right? So what do you think is the most probable diagnosis here? The most probable diagnosis here. Smoking history is there, elderly person, and I can obviously take fatigue, anorexia or loss of appetite is a possibility. Deviant shared it's a squamous cell carcinoma. One important information most of you guys are missing, I'll highlight it. Tell me if it helps in any way. Serum sodium of 120 millimole per liter. This is reduced. Let's reduce serum sodium. And also you have a hilar lymphadenopathy. That also is important for me, right? So lab findings, which is important, is serum sodium levels are reduced. Have you heard about something called an SAADH? No neurological problem. SAADH, serum sodium level being reduced, is a very important clue for me to arrive to a diagnosis. It is a lung carcinoma. I'll be more than happy if you call it a lung carcinoma, but I'll be even more happy and give you more marks if you say exactly what is a lung carcinoma. A lung carcinoma which presents as SAADH as a paraneoplastic syndrome. You can write that serum sodium being reduced and the history of a lung mass. I would think of a lung cancer with SAADH. What cancer is this? Anyone? That will most probably be a small cell carcinoma of lung, right? So lung cancer, most probably a small cell carcinoma of the lung because of the paraneoplastic syndrome of SAADH, syndrome of inappropriate age segregation, right? So this will get you the exact all the points of all the marks for the part A of the question. If you rate lung cancer, you're not wrong. But since SAADH isn't there in the history, I would expect you to write small cell carcinoma of the lung because that is very, very, very accurate, right? Sheetal adenocarcinoma will not have SAADH. Small cell carcinoma will have SAADH and your Cushing syndrome. Squamous cell carcinoma will have hypercalcemia as a paraneoplastic syndrome, right? Amongst the lung cancers, fine? Harishan. Okay, so that is the clinical data points here and the most common diagnosis. Let's go to the next one. We'll do the same thing, 3-4 things, and we'll go to a template to understand and revise quickly about the lung pathology. It's a very easy one. I am sure you know the diagnosis. I don't know the diagnosis. I want the clinical data points available here, which helped you to arrive to a diagnosis. Diagnosis is very simple, right? It's a simple case of an asthma. COPD and asthma is the easiest diagnosis here because history, there's a 5-year history. So it's not something which is acute, it's recurrent, right? So it's a 5-year history or recurrent history or recurrent episodes. Again, it's not being present throughout. It's episodes of shortness of breath, or I can say breathlessness, and wheezing. Wheezing is a very important finding here. Chest tightness also. On exposure to cold and dust are trigger factors. On triggers, you can just write triggers. Anything can be a trigger for asthma, right? And the patient's treatment is relieved by inhalers. Inhalers improve the symptom, which means that okay, the patient is having some of the bronchodilators which is going to make the symptom better. It's a very simple thing of an asthma. Fine. Okay, Arishankar, that's with YouTube policy. We can't control that, right? I'll ask them to remove it if possible. Fine. Okay, perfect. Recurrent history is important. Wheezing is important, and it improves on using an inhaler is important. And all these episodes happens after a trigger. Most of them will miss this point. See, because trigger is something which tells me exactly, okay, this is hypersensitivity induced or a type 1 hypersensitivity induced here, right? Okay. See, Ipshita, emotional stress also triggers asthma. Exposure to cold air, hot, dust particles. There are many triggers for asthma. One of them is that. Fine. Okay, just keep that in mind. Not very often, but one of the trigger could be an emotional disturbance as well. Fine. So it's a simple case of an asthma. Or you can write an chronic obstructive pulmonary disease, asthma. Okay. Perfect. Trigger is important. Please don't miss the trigger because that's something which I would expect you to pick it up in a clinical scenario before just looking at the V's and writing as asthma. Fine. Okay. Let's go to the next guy. Tell me what could be the diagnosis. I don't want the clinical data points. What do you think? Diagnosis is simple. Age might help here, might not help here, but since there's a 60-year-old, I can definitely write Devansh is spot on. It's not a difficult diagnosis at all. It's a simple case of a myocardial infarction, right? The way by which I reach to myocardial infarction is what is very important here. Fine. Okay. Rishang, we had discussed about exercise-induced asthma, cold-induced asthma as well in the regular class. Just go and have a look at once again. Fine. Perfect. Okay. Mumbai Indians is the diagnosis. You have a crushing pain, retrosternal pain, radiating to the jaw. That also is important. Nausea, diaphoresis, right? Clinical symptomatology of an acute onset retrosternal pain or a retrosternal radiating pain, because radiating pain is also very classical of an MI, right? That one. Plus, there's a history of risk factors. Do write them as well. The patient is type 2 diabetes mellitus. Patient is hypertensive. There's a history of risk factors there. And in addition to that, to confirm the diagnosis, I have ECG changes of ST elevation. Not just that, because ST elevation can be seen in, I just want one answer. I want you guys to comment this answer. Do you think is it MI or do you think is it angina? What do you think is the right answer? What will you write? If I have to confuse you, is it angina or is it MI? Angina is chest pain, MI is myocardial infarction. Both are different, right? Angina is ischemia, MI is infarction. Will this be angina or MI? What would be the right one? Since there is trope I elevated. Trope I elevation is the reason which can happen only after a coagulative necrosis, loss of cell membrane, leakage of the intracellular content, then I'll be writing as MI. Because of this MI, not because of the rest of the finding. Angina also will have the same history. Angina will also have the same risk factor. Angina will also have ST elevation, but angina will not have troponin elevation. If troponin I is not elevated in the question, I would still prefer angina could be an appropriate answer, not an MI. The only difference here is angina, there will be normal cardiac enzymes. If you want, right, MI, there will be elevated cardiac enzymes. Fine, there's the only difference between angina and MI. Please look into it. Look into the question carefully and write the diagnosis, right? Perfect. Okay. That's fine, Rishan. Okay, perfect, right? Next question. Very simple one. I know the answer. Again, I don't want the diagnosis. Tell me what are the data points or the clinical points which leads to the diagnosis. The triangle one is obvious diagnosis. If you are very comfortable diagnosis, call it diagnosis. Not comfortable, use the term differential diagnosis. Age here, yes, to some extent it might help because this disease predominantly happens in a young age group. Fine. Though not mandatory, but predominantly happens in children. Murmur is the last one, Srimati, right? Okay. There is a untreated sore throat. So I do have a past history of sore throat or a past history of URI. So when I have a past history, see, the history, present or past is important. Sometimes past history is also relevant for me. Like risk factor is relevant for MI, for this diagnosis, past history is relevant, right? In addition to that, you have a joint pain, or you can write in terms arthritis, and also there is a murmur. So which means there is carditis. Arthritis, carditis, joint pain, obviously the patient has fever as well. All points down to most likely diagnosis of an rheumatic acute, okay, you guys will write acute rheumatic fever or rheumatic heart disease. What do you think will be the better answer here? I'm okay if you write both, any one of them, but what would be the most appropriate thing? Shital, it is not an infection of a joint pain, right? All these are molecular mimicry. I would use the term inflammation. Inflammation is a better term than using the term infection, right? Infection is there only in the throat. The most likely diagnosis here will be an acute rheumatic fever, because rheumatic heart disease always means a chronic rheumatic heart disease, right? RHD is always for chronic. The term acute rheumatic fever is a very appropriate one, but it's fine. You use both of them, it's completely fine, right? Now, I just want you to push you a little bit. Can anyone tell me what could be the problem in the heart valve? Any possibility? What could be the problem in the heart valve? What could be the problem in the heart valve? Any possibility? I do have a murmur, systolic murmur heard in the apex radiating to the axilla. Okay, if possible, right, might be due to mitral regurgitation. Okay, if possible, right? If you've gone to your medicine postings, vegetation might not cause the murmur here. Rheumatic heart, acute rheumatic fever will cause mitral regurgitation. Stenosis will be a diastolic murmur. Regurgitation will be a systolic murmur, right? Rough rambling, mid-diastolic murmur is for stenosis. Systolic murmur is for regurgitation. Again, just to push. If you can relate to your medicine postings and write, great. Otherwise, rheumatic heart fever, acute rheumatic fever is more than enough, right? So just to give you a brief, systolic murmurs will be in MR. Mid-diastolic murmurs will be in mitral stenosis, right? You'll read more of them soon, fine? Sure, Shang. Once we complete, we'll do it for sure, okay? So this is the same template what we are going to do in all the FARRE to make sure you are okay to appreciate any clinical scenario based question, whether you know or not. I can have a systematic approach. Once you have the approach, diagnosis or even close to the diagnosis is more than enough for us, right? So now what to do for the template for CVS and RS. So this template I would want you to keep for most of the systemic pathology. If you've seen the template of yesterday's, I didn't have this term of definition. See, in renal pathology, I don't want much of a definition except for few things, like an pyelonephritis might require a single word definition. Glomerulonephritis, PSG and FSGS might not require a definition, right? We can start from the etiopathogens directly. But a question like emphysema, I need to tell what's an emphysema first. A question like asthma, I need to say what's asthma first. Bronchiectasis, I need to say what's bronchiectasis first, right? So rest of the systemic pathology, if you can write a one-line definition in your own words, definition of just what the disease is, that's all. Emphysema is lung alveolar wall destruction and permanent dilatation, enough for me, right? Acute bronchial hypersensitivity leading to breathlessness and wheeze is asthma, enough. You need not write what is there in Robbins because no one of your examiners also knows what is there in Robbins, but I need one word, coal workers pneumoconiosis. Maybe it's a lung disorder, occupational lung disease in coal mining industries because of the inhaled particle damaging the lung parenchyma. Just a single word of what it is, so it will give a better approach. So just instead of starting it blunt with etiopathogenesis, let's start with a single word definition, right? Then we go to etiopathogenesis, clinical features, gross microscopy. I need to write the immunohistochemistry if I'm talking about a cancer, but IHC is not required if I'm talking about silicosis. Doesn't matter. Emphysema doesn't matter. I'll stop with microscopy only, right? Complication and outcome. Again, it's based on the disease. I'll either write a complication like atherosclerosis might have an outcome or a complication, right? And asbestosis might have a complication based on that, right? So based on what question you are asking, kindly change a little bit of here, right? So same way what we did yesterday, we had a page or a slide of clinical features: nephritic, nephrotic, acute, chronic renal failure. So whatever diseases, I'm just going to cut, copy, paste and add on to it. Similar way, we have few templates for CVS. You can write this for most of them. Yes, it's not complete. Okay, it's fine, Rishan. Yes, it's not complete, but it will help you to at least draw, okay, this is what I'll be seeing in case of an heart failure, MI, squamous cell carcinoma, small cell carcinoma, COPD and restrictive disorders, right? So whenever you see or write any disease with respect to a heart failure, be it like a question on cardiomyopathy, will end up in a heart failure, right? Obviously, right? Or an MS, MR, RST might end up in a heart failure, right? Progressive dyspnea on exertion, very, very important. Orthopnea, which is dyspnea on lying down. Swelling of the lower limb. If you want to use more technical terms, use the term pedal edema, right? Again, telling the heart's not able to pump and there's an edema, right? Displaced apex beat, bilateral basilar creps because of the lung overload, because of the pulmonary edema. If the heart fails, the lung is not going to able to push via the pulmonary veins. You'll have pulmonary edema and elevated JVP. You can write this as a template for any disease where you can see heart failure as the diagnosis or as a complication anywhere. Obviously, heart failure can be a complication of some other random disease also. There also I can write this. Fine. Let's say there's a random question on pulmonary embolism. Might end up in a cardiac failure, right? Cardiac arrest, cor pulmonale. You can write the same finding here, right? MI. Sudden is important. Retorsion of chest pain radiating to jaw or the arm. Diaphoresis, palpitation and nausea. Tachycardia and diaphoresis. It's repeated, ignore it, right? So these are the symptoms which could be fitting into any question of the MI, because MI, most of the questions will be post-mortem findings. That's what we'll be seeing in pathology at least. But I do need to write the clinical history for that also. So I know what to write if a question comes with an myocardial infarction. Or let's say I have a question on atherosclerosis where I write one of the complications could be MI. You can fit into that, right? Squamous cell lung cancer, small cell lung cancer. I'm going with these two predominantly because adenocarcinoma is not generally asked in your exam, but even asked, similar finding only. Cough, occasional hemoptysis, cough, weakness. This is a template for any lung cancer. Hemoptysis is generally for a lesion which is in central location, which is close to the hilum. If you have a tumor close in the alveoli, in the periphery, it might not cause hemoptysis. Weight loss, anorexia is template for almost every cancer. Loss of appetite, loss of weight. It'll always be there, right? Okay. So clubbing again can be a possibility in most of them. Hypercalcemia, do remember, this is a paraneoplastic syndrome. Lung cancers most of the time present as a paraneoplastic syndrome. I want you to remember that, don't forget it. History can give you a clue. Calcium levels was 13 milligram per deciliter. Examiner wants you to write squamous cell carcinoma of lung, not just lung cancer. SAADH, Cushing syndrome. I want you to write small cell carcinoma of lung, not lung cancer, right? Please look into it. Rest will be more or less the same, right? SVC syndrome is something which, if the tumor is very close to the hilum, which can block the superior vena cava drainage, can present with an SVC syndrome. Small cell carcinomas rarely do. Again, wheezing not often. Wheezing could be a rare manifestation because small cell carcinoma can kind of carcinoids can kind of go into the bronchus, can obstruct the bronchus as well. Fine. Okay. Now COPD. COPD, emphysema, chronic bronchitis, both of them will be falling under COPD only. Can anyone tell me what will be the disease falling under restrictive lung disease? There's one thing which is there in your CBME which will fall under restrictive lung diseases. Though there is a very big classification of restrictive lung diseases, we generally don't go into it. That's your pneumoconiosis. With respect to your second year CBME, pneumoconiosis is something which comes under restrictive lung diseases. Silicosis, coal workers pneumoconiosis, asbestosis. I do have something called an interstitial lung disease, pulmonary fibrosis, not required for a CBME, right? Every pneumoconiosis symptom will be same. I'll have progressive breathlessness, dry cough. Crackles is crepitations, right? And reduced chest expansion, clubbing. Clubbing is a part and parcel of almost every lung disorder you can write, right? Kuldeep, you're absolutely right, but pulmonary fibrosis, I'll expect you to answer it when you're in final year. For second year perspective, yes, pneumocone is important for me, right? Chronic productive cough. The most important thing about COPD and restrictive lung disease will always have a dry cough. Keep that in mind when you're solving a question. If it's a COPD, most of them will have a productive cough. Asthma, bronchitis, both are productive cough. Breathlessness will be there. Obviously, you'll be adding on extra points. Pink puffers, blue bloaters. This is a template, that's all. Barrel chest, hyperresonant, prolonged respiration, scattered wheezes, all these are possibility in different parts of COPD. If it's asthma, I would say, okay, wheeze. Pink puffers, barrel shaped chest, emphysema. Just chronic bronchitis or bronchial breath sounds, I will go for chronic bronchitis, right? So I can tune it a little bit. The only motto of giving a slide for clinical presentation for almost every FARRE what we'll be doing is, if you don't know what to write, I'll know something, some template to start with. Most of the time we have starting problem, right? This will solve the starting problem. Compile all the FARRE's clinical scenario alone. I'll only compile it for you. I'll give it to you in the end of the FARRE so that before the exam, okay, this is what I'm going to write if I'm going to have this disease. So it's sorted, fine. Now let's go to one by one disease. I'm going to go with few template ones. I will not be covering the entire CVS and lung here. I'll tell you what I'll not be covering, and I want you to do after the class. Go back to the notes of yours or the FARRE PDF which is there in the MedEd app. So just quickly go through it. So today I want you to complete CVS and lung. That's it, fine. Okay, so let's start with atherosclerosis. Template is this. Definition, one word, etiopathogenesis or risk factors if it's a risk factor, clinical features, gross, microscopic, complication and outcome, right? Rishi, you guys only answered in the live class, right? Why pink puffers and a blue bloater? Okay, forgot. I'll ask you tomorrow. Read that back and let me know. Fine. Okay. So let's start with atherosclerosis. Atherosclerosis is primarily a progressive disease of the tunica intima of the large and the medium-sized muscular as well as elastic artery. My primary concern is the large-sized muscular artery or the medium-sized muscular arteries, right? Large and medium-sized muscular elastic arteries, progressive disease of the tunica intima. If you want to add, which results in hardening of the vessel. Atherosclerosis nothing means that the vessel has become harder. That's resulting in hardening of vessel, right? So we do have risk factors here. Okay, great. We do have risk factors here. Yes, Rishan, we'll do pneumoconiosis for sure. Okay, modifiable and non-modifiable risk factors, right? For every atherosclerosis. So modifiable risk factors, all the metabolic syndrome X or all the chronic diseases, be it hypertension, hyperlipidemia, diabetes, smoking, alcohol, if you want to write obesity, or put together and write metabolic syndrome. Almost everything which will be then metabolic syndrome X is going to be a risk factor for us, modifiable risk factor. Hyperhomocysteine can be modifiable if it's due to a vitamin deficiency. Because hyperhomocysteine could be congenital, which becomes non-modifiable risk factor. If it's vitamin deficiency, it becomes a modifiable risk factor. Age, elderly particularly, is a non-modifiable risk factor. Gender, who's more prone? You guys know the answer. Men are more prone, and postmenopausal women. See, if it's a short answer, I don't want you to write all this. Postmenopausal, why postmenopausal women? You need not write. If it's a long answer, write that estrogen is vasoprotective. So during the reproductive age group, there's good amount of estrogen which reduces the endothelial damage or the risk of endothelial damage. So it's protective, that's all, right? Familial history, genetic diseases, especially of hypercholesterolemias, hyperlipidemias, right? So hypercholesterolemias and hyperlipidemias, definitely they will increase the risk of atherosclerosis. There are big risk of atherosclerosis. There are multiple types of hyperlipidemias which can increase the risk of atherosclerosis, right? So we know the risk factor, modifiable, non-modifiable. So pathogenesis or a progression. There are beautiful images in Robbins. If you are going to read with your notes, I want you to look at the images, flowcharts, because they are more descriptive. and that's what I want you to write in the exam as well, right? So in pathogenesis or progression, the first and the most important thing is, what do you think is the starting point of atherosclerosis? Can I say atherosclerosis and chronic inflammation? Yes, that's the first thing I want you to write. So atherosclerosis is nothing but a chronic inflammation of the blood vessel or chronic inflammation of tunica intima, which actually starts as an endothelial injury. It'll start as an endothelial injury, but it'll progress and cause a chronic inflammation of the tunica intima, which is going to indirectly link to the entire vessel, right? Perfect. Like Devan said, endothelial cell dysfunction or the tunica intima or endothelial damage. That's where it's going to start with. In one word, there's more than enough for me. This is what I mean by atherosclerosis. That's all, right? So if you have to write one by one step, the first step, we can use endothelial damage. To be very specific, it's a microvascular injury. It's not a big injury, because if it's a complete through and through injury for the endothelium, I'll end up in a clot. I might not go to atherosclerosis, right? Tiny damage, right? Because of tiny damage with the risk factors already being there, you can write two things: oxidized LDL. That's something which is very, very notorious, which will enter the intimal cells. So once it enters the intimal cells, oxidized LDL can trigger inflammasome. So inflammasome complex can produce your interleukins. Interleukins and might definitely undergo phagocytosis, and it will be cleared. This is the first step. Once it's cleared, at this place, I'm going to have the initial step of atherosclerosis, which is fatty streak. Okay, this is the first step. It's completely gone. Once an event, it's not a problem for me. It'll automatically be taken care of, right? But on repeated injury, repeated damage, definitely it's going to become chronic. It's a chronic inflammation, right? Acute problem is not a problem for me at all. Damages eaten away by macrophages, endothelium will come back again, right? So when it's a repeated damage, recurrent injury, it automatically becomes chronic. I'm writing in this half, but entire page I want you to write. Please make sure when you're writing pathogenesis, left hand side write the theory part, right hand side just put line diagrams. Not very complicated diagrams, very simple diagrams. I'll show you when you go to the gross thing, right? You can actually draw them side by side, so it's much comfortable for the examiner to see it. Fine. So what happens is, if it's a repeated injury, a repeated trauma, I'm going to have tissue destruction. Here, tissue destruction is equal to intimal destruction or intimal necrosis, right? In addition to that, you'll have the healing process. In the healing process, there will be the myofibroblast from media will come into the intima. This is important because intima does not have a mesenchymal tissue. Once it comes from the media to the intima, this completely will form the atheroma. Atheroma or your atherosclerotic block. Fine. Okay. This forms your atheroma or the atherosclerotic block, right? So what will be there in the diagram of this fatty streak and atheroma, I'll be drawing in the gross, but in the exam, write this in the left, draw the diagrams in the right. Fine. Perfect. Smooth muscle proliferation will be there. ECM deposits will be there, like Devan said, but that has to be a little bit more descriptive, right? Okay. So what happens actually is, if I'm going to draw, okay, this is my intima, simple normal intima, and let's say is your media. It's going to move towards fatty streak. In fatty streak, what I'll have is, I'll have a cluster of macrophages. That's all. I won't have any other change. My media will almost be the same. The only thing is, you'll have few foamy macrophages in the microscopy. So what I'll have in the gross is, you'll have yellow streaks or yellow lines on endothelium. This will not be elevated. This will be flushed with the endothelials or the vessel surface. It will not be elevated at all because they are just few cells. I don't have a destruction, I don't have a ECM deposition or smooth muscle proliferation, so it's not big, it's just flushed there, that's all, right? So once that is done, the next thing is your atheroma. So what happens in atheroma is, atheroma you has to be very, very careful while you draw an atheroma. Okay. Here images make sense, colors make sense, so do get colors. I do have in the center, I'm going to have little bit areas of necrosis, and obviously I'll have little bit foamy cells, foamy macrophages trying to eat away the necrosis, and I obviously will have the myofibroblast. Okay, and like we said in the start, it's a problem of the tunica intima. So what should be the layer below all of them? What should be the exact layer? What do we call that? The layer below all of them. This is very, very important. Do draw this layer. This layer is important throughout the image, but here in the atheroma, it makes much more sense. That's your internal elastic lamina. So what exactly is happening is, it's happening above the internal elastic lamina. So it's happening in the tunica intima. And please draw the endothelium back. It's a single layer of endothelium. Endothelium will always be in the back. It will heal, right? So that's an atheroma. And if you want to keep your media here, put just tunica media here, right? So this is an atheroma. So atheroma grossly, it will be elevated yellowish plaque. See, plaque means it's elevated, and it's an elevated plaque on the surface of the vessel. Atheromas are more common at bifurcations or at the branches, right? They're always more common at branching points, because at branching points there is more of your turbulent flow. It predisposes to atheroma formation. Fine. Okay. Atheromas, the other name is, they are also called as an atherosclerotic plaque, or I use the term neointima. It's a new intima or neointima formation, right? So when you draw an atheroma, yeah, because of the, I did tell this in the class as well, Trishang, it's because of the milk, the animal milk what we are drinking is kind of going to cause that problem, because it's difficult to digest them, it can get deposited, right? But without other history of risk factors, it will stay with fatty streak only, right? Now here, when you draw an atheroma, my parts are very, very important, right? You can write that I do have a, what is the top layer called as, and the central one. We do have a fibrous cap. If you want elaborated, fibrous cap is predominantly formed by smooth muscle proliferation or a myofibroblast proliferation and extracellular matrix deposition, right? And then you have a necrotic core. Or if it's a 5-mark question, just write necrotic core, that's enough. Which means I do have necrosis, we do have foamy macrophages, foam cells, which is engulfing the fat, and also some amount of smooth muscle cells, which is engulfing the fat as well, right? So I have a fibrous layer or a fibrotic cap and a central necrotic core, right? So that is enough for me to call it an atheroma formation, right? So we know the gross, we know the progression, which will exactly tell what is meant by atheroma. Fine. Perfect. Great. Now let's come to microscope. Actually, what we saw here is the microscopy. But since I have to write, it's better, this is an image from Robbins. You can draw like this or just explain that and only write it here, right? Sorry. Okay. So fatty streak is the first layer. And what I'll be seeing in fatty streak is, I'll only see foamy macrophages and there'll be no other thing. When it goes to atheroma or a atherosclerotic plaque, I want you to write two things, uncomplicated ones and complicated ones. Because why I want you to write the uncomplicated complicated is, when I go to the outcome, I'm going to take care of the complicated and the uncomplicated one as well. Can you share me the PYQ, Sartak? because if it is plaque, it involves all of them. The stage of the plaque is important and the place of the plaque is important. If it's a central core, my answer will be different. It's a fibrous cap, my answer will be different. Earlier, later atheroма, my answer will be different. Fine. Okay. We'll do the same thing. So the entire goal of FARRE is to present in the exam. That's all. In an uncomplicated atheroma, I'll have the fibrous cap. So the fibrous cap will have your smooth muscle cells, your extracellular matrix, and your necrotic core. Precisely, this is what I was saying, Sarthak. Like, it will have your necrosis, it will have your foam cells, it will have all of them, right? Okay. The foam cells include both your macrophages as well as smooth muscle cells, which are able to engulf the fatty tissue. Fine. Complicated atheroma, on top of it, you might have fissures or rupture of plaque, and always it will be added by superadded thrombosis. That's how complicated atheroma looks. You'll have a superadded thrombosis, because complicated atheroma is the reason for your unstable angina or an immediate stroke and all of this sorts, right? I can have two things in atheroma, complicated and uncomplicated. This here, what you're seeing is a very simple, normal, uncomplicated atheroma. We have the central core, we have the fibrous cap, we have the lumen here. So atheroma will primarily reduce the lumen, so that's why we have all the complications of coronary artery disease and stroke here. Fine. So this will be for the microscopy. What could be the outcome of atherosclerosis? We can have lots of outcomes of atherosclerosis. You can write n number of examples for each of this, because you have completed pathology in second year. You can easily write many examples for this, right? I can have atherosclerotic stenosis, narrowing, that's all, right? So it is just narrowing of the lumen. So in narrowing of the lumen, can I say it can result in ischemia? It will result in ischemia, right? So instead of writing ischemia, I can give an example. It can result in angina. A simple, stable angina, that's all. Because in stenosis, that's all, right? If it's critically narrowed, if you have critical stenosis is something which is more than 90% of the lumen being reduced, which can result in infarct also. But critical stenosis is a little bit unlikely, because repeated episodes of angina, the patient will come to us and obviously the doctor is going to intervene, right? Rupture, ulceration and erosion, all these are secondary changes in atheroma or secondary changes in the plaque. Whenever you have secondary changes in the plaque, this might result in your unstable angina. It will happen all of a sudden and always have the superadded thrombosis blocking it, right? Or an MI. Most of the MI, sudden MI is good due to your unstable angina only. Stable angina will cause chest pain. Unstable angina will completely block it, MI, so it will primarily result in infarction. Right? And atheroembolism. This atheroma, once the rupture happens, the central core, the fatty core can escape, right? So you can see the central fatty core going, and it can actually block arteries, renal artery. The reason why I'm saying renal arteries, aorta is one of the important places where you can see atherosclerosis, abdomen aorta, and one of the bigger branches from the abdomen is renal artery, so it can go and get blocked there, right? Renal artery atheroembolus, which is nothing but the fatty core and going blocking, is also an outcome for atherosclerosis, right? Last but not least, aneurysm. The entire plaque, it's just nothing but TDHF, will obviously weakens the wall of the vessel. Once this weakens the wall of the vessel, it will definitely lead to aneurysm. Atherosclerosis is by default one of the most common cause of aneurysm, right? Just 4 things. This is actually enough for a long answer also. Long answer, 10 marks, right? 2, 3 marks or 4 marks will be allocated for your diagnosis. Why it is 2 marks? 2 marks for outcome, microscopy, gross, pathogenesis, risk factors. Actually enough for a long answer. Atherosclerosis should unlikely be asked in a short answer. If asked in a short answer, please stop at some point of time. If a long answer comes in a short answer, the only problem is many. You will not be able to stop it at some point of time. That will consume your time. So make sure short answer 1.5 page. Don't write more than that. Long answer 2-3 pages. Don't write more than that. That's more than enough, because they are not going to give you extra marks just because you wrote 5-mark question in the extent of 10-mark answer. Right? Try to reduce it, try to cap it, and try to expand it based on the marks which has been awarded. Please don't write whatever you know, doesn't matter. Whatever is asked matters, fine. So let's go to the next topic, rheumatic heart disease. Okay. There are few missing points here. Can anyone tell me? It's a simple thing, right? 20 marks. There'll be two. What's missing here? Rheumatic fever is an acute. Can I just write it as post-streptococcal, or it should be like something else? Okay, I'll leave it to you guys because it differs based on universities. So if it's a 10 mark, write appropriately. If it's a 20 mark, write appropriately, right? Okay. Is it just post-streptococcal, or we have some other like alpha, beta, group A, group B, all of them? Rheumatic fever is an acute post-streptococcal immune-mediated multi-system inflammatory disorder. It's multi-system. It's not primarily a heart alone, right? Okay. We'll not go into the marks. We'll stop with LAQ, right? We have different marks here, right? Do we miss anything here? No. Do I need to add anything in the streptococcal? Group A, Group B, beta hemolytic, alpha hemolytic. Group A, beta hemolytic, streptococci, right? That will be a better one, right? Perfect. So if you want, right, Group A, beta hemolytic streptococci, right? It's due to a Group A beta hemolytic streptococci, post-streptococcal and immune-mediated multi-system inflammatory disease, rheumatic fever, right? So etiopathogenesis. It's a very simple etiopathogenesis. See, you will write a flowchart for every pathogenesis, but I want you to write what is the primary thing. Like we wrote a big flowchart for atherosclerosis, but the first thing, chronic inflammation starting at endothelial damage. The same thing here. If I want to describe in one word, what will be the word an examiner will be looking for rheumatic heart disease? That will be the word I want to tell in the Viva as well. What will be the word? Why is there a problem in the joints and why is there a problem in the heart for rheumatic heart disease? I want that word to be first. It's going to be molecular mimicry. Don't even let them go and read your entire story. I want to look for this, that's all. If you have written the word molecular mimicry, I know that you know the concept of rheumatic heart disease or rheumatic fever. Doesn't matter for me, right? That's more than enough. That's what I'm going to look for here, right? Cross reaction or a molecular mimicry is what I'm going to look for, fine? So when you have an URI or sometimes a skin infection by a group A beta hemolytic streptococci, fine. So obviously my body will be eliciting an immune response, right? So once it's eliciting an immune response, and this group A beta hemolytic streptococci has some proteins called as an M proteins. So the M proteins of the streptococci mimic human tissues. So that is the main problem here. So the M protein mimic human tissues. So when my immune system is going to destroy the M protein, I'm going to have a cross reaction or a molecular mimicry or a bystander effect, which is going to destroy the heart, joints and everything as well, right? So when you have an immune response, which is mounted against the streptococci, same immune response will also destroy human tissue because of the molecular mimicry. That's it, right? This you can write as an bystander effect. Okay, because my human tissue didn't do anything, but it's getting destroyed because of the molecular mimicry. That's it, fine. Okay, I need the term molecular mimicry. That's the only term which I'm expecting from you in a Viva for pathogenesis or in an exam 5-mark question for pathogenesis. If it's there, that's enough. And maybe I'd also expect this word, the M protein. If you are great, write the number of M proteins. If not required, leave it. Because even if you write the number of M proteins, most of them will not remember it. M protein I remember. What subtype of M protein is not required for me, right? Group A beta hemolytic is important. M protein is important. Molecular mimicry is important. So there's a cross reaction and it gets destroyed. So it's an immune mediated destruction because of cross reaction. As simple as that, right? So next, for my clinical features. Clinical features with respect to rheumatic heart disease is criteria based diagnosis, right? Can anyone tell me what criteria? So we have modified Jones criteria. Everyone knows the name, so I want you to write it. Though it's something which is clinical, modified Jones criteria will be asked in your Viva and pathology, microbiology, medicine, pediatrics, everywhere, right? We have major and we have minor criteria. Arthritis, write it based on the time available and on based on the marks as well, right? If it's a long answer, I want you to write it completely. Migratory polyarthritis of the major joints. That's how it's exactly right? So it has to be migratory. It has to be an polyarthritis of major joints. It's predominantly the knee or the elbow. It will not involve your phalangeal joints. Fine. Pratyush, generally no. If you're a good student, you need books and patience. That's all. That doesn't restrict yourselves to college, right? Join. Let's read more. Okay. Carditis. Primarily, I'll have pancarditis, where I involve the endocardium, myocardium, and your pericardium, or you can write bread and butter pericarditis as well, right? Chorea, we have the Sydenham's chorea. It's a chorea along with the change in the voice, right? Sydenham's chorea is a late feature. It's not an early feature, it's a late feature with respect to the major criteria, right? Perfect. Erythema marginatum, please don't write nodosum. If you forget whether it's marginatum or nodosum, stop with erythema. It's okay to write half than to make a mistake, right? And subcutaneous nodule, both are skin related things which I can easily see in case of a major criteria. Minor criteria, fever, arthralgia, elevated inflammatory markers, which can be your ESR, which can be your leukocytosis, whatever it is, fine. Okay, send white as dance, you can write as well. Again, expand if it's a long answer. Just write polyarthritis, pancarditis, chorea, marginatum, and subcutaneous nodule if it's a short answer, fine. Okay, perfect. So now, once I know the clinical features, I know the pathogenesis, I have to come to gross microscopy, probable outcome. That's all, because that was a template for every question here, right? Gross, I want to divide to acute and chronic rheumatic heart disease. Chronic, acute is rheumatic fever, chronic is always rheumatic heart disease, right? So in acute rheumatic fever, what are the findings you will see in gross? There are two things I want you to write in gross and acute rheumatic fever. One is the valvular pathology. In the valves, you might see vegetations. Vegetations will be seen mostly in the acute rheumatic fever. Not Rashank, not much in depth. Let's not go into that, right? Yes, it's seen only in a few. There will be a predisposition, but not exactly well formed, fine? Okay. These are verrucae or tiny projections seen on the edges of the valve. And most of them will have, in acute rheumatic fever, will have mitral regurgitation. Mitral stenosis is not something seen in acute phase. Acute phase will always be regurgitation. Stenosis is always due to fibrosis, which is always a hallmark of chronic disease, right? So valves in acute rheumatic fever have vegetation, mitral regurgitation. And one more important thing, there's a plaque, a named guy's plaque. What's the name? Because of the regurgitation, I'm relating to the next point. Regurgitation of mitral valve, the blood from the left ventricle goes and hits my left atrium, keeps on hitting the left atrium, and will cause a plaque or an irregularity in the left atrium that was discovered by McCallum. So we have a McCallum's plaque. So McCallum plaque is nothing but irregularity in the left atrial wall due to the regurgitating blood of mitral regurgitation. Okay, it's due to regurgitating blood of your MR. Okay, Shreya, we'll do it later. Just you have a Telegram group with all your seniors and all of us. Ping us there, and we'll definitely take care of it. Don't worry about it. Fine. Okay, these are two things which is bare minimum requirement for an acute rheumatic phase. Gross, both are gross findings, right? Chronic rheumatic heart disease. Again, I'll go with the valve. Valve, I'll be having more of stenosis lesions, predominantly mitral. It can also involve other valves, pulmonary, tricuspid, aortic can be involved, but predominantly mitral, right? Mitral will be involved predominantly, but it can also involve other valves, right? And there are few named findings. What are the named findings? What are the named findings seen in case of a mitral stenosis? You have, perfect, you have your fish mouth appearance. That's something which is required, which will change right? And also you might have anything else. A wet fish mouth appearance is something which is very common in case of a chronic rheumatic heart disease, and you'll have fusion of the valve leaflets or the commissures. Fusion of the valve leaflets or the commissions is also something which is seen in case of a chronic rheumatic heart disease, right? So how do I describe them? If I want to write gross diagrams are important. Chorda tendineae, draw the valve, and tiny red dots or any color, call them vegetations. Something is very simple to draw, right? A normal tricuspid valve which has become a fused tricuspid valve. You can write, okay, it's stenosed or fused. So I can say it's stenosed. See, these are simple line diagrams to make it a little bit more appealing for an examiner, right? You need not be very draw very beautiful diagrams. It has to be descriptive line diagrams. That's more than enough for me to say, okay, this is what will happen in acute, this is what will happen in chronic, right? Then microscopy, we have the classical finding ash of bodies, right? Ash of bodies, what is ash of body made of? Because ash of body, if you how many of you university has two mark questions? Because ash of body is something which is very important when you have something of a 2 mark question, right? So ash of body is nothing but it's a foci made of activated macrophages called as Anitkov cells, T lymphocytes, few plasma cells, and also fibrinoid necrosis, right? It's a very pathognomonic finding in case of a rheumatic heart disease. The first, it's a pathognomonic feature of rheumatic heart disease as well as acute rheumatic fever. It is seen in both acute rheumatic fever and also in chronic rheumatic heart disease, but it's a little bit more common in acute rheumatic fever compared to your chronic rheumatic heart disease. Fine, okay? Because if it's a 2 mark, ash of body can come as a 2 mark, right? So ash of body, what is composed of? It's actually a collection of lymphocytes, plasma cells, and macrophages. See, it's actually kind of a very ill-formed granuloma. That's what ash of body primarily is. Same thing we have in the granuloma as well, right? So these macrophages are also called as Anitkov cells. Okay. So one important thing I'll be looking in Anitkov cells is, apart from the abundant cytoplasm, every activated macrophage will have abundant cytoplasm. The most important thing is the wavy chromatin, right? So these Anitkov cells will have increased amount of pinkish cytoplasm. In addition to that, you have the caterpillar chromatin. I'll be looking for this caterpillar chromatin for sure. Fine. So do you want to draw a diagram for ash of bodies? Because diagram obviously looks good when you have a decent presentation, right? So when you want to draw a diagram, first draw the muscle. It's a cardiac muscle, right? You can just draw a cardiac muscle and maybe put striations here and all the connections here. Simple. So it's a collection, right? You know how to draw a lymphocyte. Lymphocytes are small round blue cells. You know how to draw a plasma cell. Very occasional plasma cell, right? And obviously, I need to draw Anitkov cells, right? So I have cells with a pinkish cytoplasm, and I'm going to have nucleus with wavy chromatin, right? Just a collection. Obviously, everything will be there in a background of fibrinoid necrosis. That also is required. And it's entire ash of body will also have fibrinoid necrosis. If you want to draw diagrams, even if you feel you are not good enough to draw diagram, draw this. Okay, Rohit. We have different university exam. I hope the NMC also standardizes the marks in the future, so it's much comfortable for us. Fine. Rishank, McCallum blocks in chronic, it will become stenosed. When it's stenosed, I won't have the regurgitation, right? So it's a bit more common in an acute rheumatic fever than in a chronic rheumatic heart disease. Fine. Okay, that's how it is. And the outcome of rheumatic heart disease is going to be the valvular stenosis. You'll have valvular stenosis. Because of the valvular stenosis, you might end up in having a cardiac failure. That will be the outcome of any patient with rheumatic heart disease. Okay. Rest of the things of joint is not much of a concern. The primary concern for me is the carditis, primarily endocarditis. The valve problem is the outcome of rheumatic heart disease. Fine. Okay. Do well, Eunice. Okay, so that's for rheumatic fever and rheumatic heart disease, right? So we know the definition, one word, just an introductory part. The pathogenesis molecular mimicry word is important. Jones criteria, major, minor. Please include all the majors. Don't fumble with erythema marginatum or nodosum. Just erythema is more than enough. And gross, divide to acute as well as chronic. Fish mouth is something which I'll be looking for. Macellum plox will be something I'm looking for in an exam. Microscopy, ash of body. If you can draw a diagram, great. Otherwise, just describe ash of body. That also is more than enough. Fine. Okay. Now, let's go to occupational lung disease or pneumoconiosis. There are two things which are common in pneumoconiosis. That will be the first thing we'll be talking about. Because when you go to coal workers pneumoconiosis, I will not talk about this. But this is what has to be there in the pathogens of coal workers pneumoconiosis also. This is what has to be in the pathogens of your silicosis also, right? Or any of the pneumoconiosis for that matter, right? So there are two things which is there. One is what happens and also the etiopathogenesis part. So there are few things which determines the risk of pneumoconiosis. The risk is dependent on few factors. Okay, we did read about the particle size. That's something is very important for me, right? Okay, we did read about something called as particle solubility. That also will determine how severe the patient might have a pneumoconiosis, right? Okay, fine. So the first thing is dust retention. More the dust is going to stay in the lung, more the problem is, which is primarily based on the concentration of the dust in the air. That's a parts per million concentration, and also the mucociliary clearance, right? So here, more retention is more problem. Okay, second, your particle size. We have something called danger particle size. Something between 1 micron to 5 micron will stay in the alveoli, and that's going to cause more alveolar damage than something which is smaller or than something which is bigger. Third is particle solubility. If the particle is more soluble, it goes generally a particle is highly soluble, goes into the lung and causes more rapid injury, right? More soluble the particle is, there'll be more injury. In addition to this, you can write based on when you come to silicosis, quartz is more fibrogenic. That's an extra point. When you come to asbestosis, we have your amphibole and serpentine fibers. That will have a clear distinction. That's an extra point, right? This is something to start with. That's all. Most common is definitely silicosis. We'll look into it, Apshita. We'll make sure we won't have any confusion. Fine. This one. So next, what will happen in the pathogenesis? See, silicosis, coal workers pneumoconiosis, asbestosis, all of them are grouped under fibrosing disorder of the lung. It's not a granulomatous disorder of the lung, it's fibrosing diseases of the lung. So this is what the word I'll be looking for. Like molecular mimicry, I'm looking for this in your pneumoconiosis, right? So what happens is simple normal thing. Long answer, explain the entire granuloma formation, end up in having fibrosis. Short answer, simple. The particle is inhaled. The particle reaches your alveoli. In the alveoli, I'll have the macrophages engulfing the particle. Macrophage cannot destroy the particle, so they result in a non-necrotizing granuloma. But unfortunately, it will not stop there because there is a repeated exposure. It's an occupation, right? It will not stop in a day. It's not like TB. Every day it will keep on adding to it. Repeated exposure ends in fibrosis. This is the pathogens for every pneumoconiosis. You can include the interleukins, interferons, activated macrophages, how a granuloma is formed. If it's a long answer, just write this if it's a short answer. Fine. But this is the template for almost every pneumoconiosis. The particle risk is determined based on the size, solubility, and the retention capacity. Tobacco always increases the risk of pneumoconiosis because it reduces mucociliary clearance. And I have a pathogenesis ready, right? So now what should I write for coal workers pneumoconiosis? So for every pneumoconiosis, I want to write the work. Which work will predispose? What are the particles I'm going to talk about? Same for silicosis. Work, particles. Ipshita, the only thing which will tell me whether it's silicosis or a pneumoconiosis is the occupation. Sandblasters, stone cutting, ceramic manufacturing, silicosis. insulation, cement, shipwrecks, asbestosis. So occupation. Occupation determines everything. Cotton wool, bicynosis. I'll have the same risk factor, same pathogenesis, occupation changes, that's all. Okay, so I need the occupation to be first, coal mining, right? You're right, Mishra. And we have the particles. Anthracite coal will causes or increase the risk of coal workers pneumoconiosis. I do have one more coal called as bituminous coal. Bituminous coal, which is seen in wood. When you burn wood or the firewood burning causes bituminous coal. Yes, Satak. So firewood causes this and it increases the risk of lung cancer. That's the other type of particle which also is involved in coal, right? So when you come to the pathogenic model here, there are three things here. We have your simple coal workers pneumoconiosis. Like Satak said, I have the coal macule and the nodule. Before even that, I have anthracosis. Anthracosis is not an occupation. You and me also will have anthracosis, right? And then we have complicated coal workers pneumoconiosis. In all these three, there are three parameters I want to look for. What will happen to the patient, right? The symptoms. What will happen to the gross? What will happen to the microscopy? You and me have anthracosis. It's pretty common, right? It's not occupational. It is even seen in urban livers. It's seen in people who smoke. Very common. It's just an anthracotic pigment. So it's not a lung problem. So they are almost always asymptomatic. So will I have a nodule or a macule in the gross? No. But I'll have black deposits or black color in the gross. I can have black color in the hilar lymph node and I also can have black color in your lung parenchyma, right? Thank you, Urban. Right? You can have that, right? So in microscopy, what I'll have is I'll just have pigmented macrophages. I won't have any nodule, any macule, no granuloma. Because it's normal, it's not occupational, but this is the starting point of coal workers pneumoconiosis. Actually, these two are occupational. Even if you live in the most polluted city for 100 years, it will not become simple coal workers pneumoconiosis. That's purely occupation, right? So like what Satak said, I'll have coal macule and coal nodule here, right? Tiny, tiny macules and tiny, tiny nodules here, right? So this patient will have symptoms of the restrictive lung disease, dry cough, breathlessness. I'll have the same thing here, right? So I do have difficulty in breathing or breathlessness. But the most important thing, reversible, irreversible. I want you guys to comment. Simple coal workers pneumoconiosis is absolutely reversible. That is important for me. That's a reversible finding. The reason it's reversible is in microscopy I have non-necrotizing granuloma. Granulomas are reversible, right? TB is reversible. TB is not permanent. It will come back to normal. So if I have a granuloma in the microscopy, granuloma is a collection. Can it form a nodule? Like Satak said? Yes. So I'll have here coal macules and coal nodules. Tiny, tiny ones. Tiny, tiny macules and nodules. Almost everything less than 1 centimeter. It'll be tiny ones, right? Macules are like 5 millimeter and above. Macule. Nodule less than 1 centimeter, right? Everything should be less than 1 centimeter. Ultimately. There's no fibrosis component here at all, right? Then let's go to the third one. Complicated coal workers pneumoconiosis or progressive massive fibrosis. Okay. So progressive massive fibrosis, here again I'll have the same symptoms of restrictive lung diseases, what we had read in the table, but the most important thing is it is irreversible. The reason is irreversible, I'll have 1 to 10 centimeter fibrotic lesions. It's not nodules anymore. It's gone. It's end. It's not granuloma anymore in microscopy. In microscopy, I'll have completely destroyed lung parenchyma with fibrosis. Okay, that's how it is. Just one question to end with. Will pneumoconiosis end up in having a cancer? Yes or no? So there's enough for pneumoconiosis. Again, if you want, write in the form of a table. Or let's say first few lines I write for anthracosis. Next few lines I write for simple. Next few lines I write for complicated. Do that. Whichever is comfortable for you, write that. Images Not required. If required, put a box, draw empty space of alveoli, draw a fibrotic pink color with black spots. Complicated. Granuloma like thing with black spots. Simple. Only black spots, anthracosis. You can even draw diagrams if required, right? Perfect. Okay. So this will not cause a lung cancer, but this will cause lung failure. Because simple coal workers pneumoconiosis, like I said, it will not cause lung cancer because bituminous coal is not seen in coal mining industry. Coal workers pneumoconiosis will not cause lung cancer, it will cause lung failure only. Fine. So let's come to silicosis. Similar way, these two doesn't change. First two, I write this for silicosis. Next is, I write the pathogenesis, sorted, right? Then I'll write gross microscopy and risk factor. That's all. So gross, predominantly silicoses are fibrotic lesions of the upper lobes. They produce big fibrotic nodules on the upper lobes of the lung. And they also have a very classical gross finding or an X-ray finding in case of hilar lymph node. So in a hilar lymph node, what happens is they do have something called an egg-shell-like calcification. So you'll have calcific deposits just below the capsule of the lymph node, right? So you'll have eggshell-like calcification that is classical for silicosis. Microscopy, there will be purely non-necrotizing granuloma. It will not stop with non-necrotizing granuloma. It will very quickly go to fibrotic lesions or a fibrotic nodule. One more most important thing, I told in your coal workers pneumoconiosis, it will be black in color. Silica is not having any color. Silica will not have a color, but silica will be, there will be positively birefringent particles. They are positively birefringent particles. When you use a polarized light, you can see the birefringence. Under polarized light, so I can say definitely it's a silica particle. That's definitely will be there in case of a silica nodule. The risk, quartz, which is extremely fibrogenic, can definitely cause very fast lung failure. It will result in pulmonary failure and restrictive lung disease. Sometimes can be very accelerated. Same time, a long-term complication, it does increase the risk of lung cancer. See, it may look like 4-5 lines only. That's enough. Along with the pathogenesis, which will form the entire structure for the question, right? Quartz is extremely fibrous, which will cause pulmonary failure, respiratory failure, and there also increase the risk of lung cancer as well, right? That's simple. Same for asbestosis. What work? Second, the risk factor, the pathogenesis. Along with the risk factor, add this. Serpentine fibers are malleable fibers. They are commonly used fibers, but they are less pathogenic because they can escape the alveoli, so they are less pathogenic. Amphibole fibers are very sharp and straight fibers. Fine, great, and they are more pathogenic. Fine. Ipshita, you asked me a question, how to differentiate silicosis and an asbestosis clinically. One is the occupation, right? Second, one of the important thing what Arpit has told us is the lobe involvement. Silicosis almost always involves upper lobe. Asbestosis is predominantly in the lower lobe. Keep that in mind. Microscopy, if they give, it's easier, right? Asbestos body, if they give, that's very easier. But they predominantly involve the lower lobe is something which will help us clinically saying, okay, next day finding predominantly involving the lower lobe. Think in terms of asbestosis, more in terms of silicosis. Fine. Okay. Perfect. Okay, great. So the etiopathogenesis factor, you know, I have to fill it up, and lesions. Multiple lesions in asbestosis. Pleural plaque is the most common. It is seen in the basolateral and in the basal and the lateral surface of pleura. They are asymptomatic. They won't cause anything. They're just incidentally diagnosed on an X-ray. When you take an X-ray, you can appreciate them. They are an incidental diagnosis. You take an X-ray for something else or as a part of the control routine checkup, you can see thickening of the pleura. That's all. You can have pleural effusion. You can have interstitial lung disease. That also possible in case of an asbestosis. Last but not least, it can also cause lung cancer. Not just lung, extrapulmonary cancers as well, right? Last Because silica is extremely fibrogenic, right? Whenever I have more fibrosis, there's more destruction. When there's more destruction, you will end up in having more free radicals by default. Same pathogenesis, right? So again, you guys already told the most common cancer is going to be lung adenocarcinoma, and our specific cancer is going to be mesothelioma. Okay, that's going to be a specific cancer. Extrapulmonary, we read something extra in extrapulmonary. Renal cell carcinoma, asbestos can be a cause. Ovarian testicular cancer, asbestosis can be a cause. Fine, it's not only the pulmonary cancers, extrapulmonary cancers can also form, right? So what do I see in microscopy? So microscopy, obviously I can see non-necrotizing granuloma to start with, which will 100% move to fibrosis, right? And microscopy will have ferruginous bodies or the asbestos bodies. These are dumbbell-shaped fibers of asbestos coated with iron or coated with hemosiderin. If they are hemosiderin, you can add on to a word. They are undoubtedly, there'll be Pearl's positive structure or Pearl's Prussian blue positive structure. That's how your asbestos or your ferruginous body will look like, right? You can draw a diagram here. If you want to draw like a dumbbell, you can draw like a dumbbell. If you want to put an pearl stain, just draw the same dumbbell in blue color, that's all. In the background, I want you to say, okay, there's an alveoli here. Okay, just mark them, that's all. I need to know it's an alveoli. I need to know these are the dumbbell shaped asbestos fiber, right? See, ultimately, it's not about how beautiful the diagram is. Please don't worry about it. No one cares about your artistic skills. If you're good, great. But please remember, just because you're not good in drawing a diagram, it's not an excuse to get less marks in the university exam. It's a descriptive diagram. You know how it looks like. That's enough for me. Because I want you to know how the patient will present, how I'm going to diagnose, how I'm going to treat. I'm least bothered about how beautiful your OPD tickets and your case sheets are going to be. Everything is computerized these days, right? But descriptive diagrams will make the at least the examiner understand, okay, they have tried something, right? Not empty, not very black and white paper. Something here and there will make it much more comfortable for the examiner to read through it. Fine. Okay, that's for pneumoconiosis. So we know about pneumoconiosis template and fit into multiple things. Every clinical feature of pneumoconiosis will be like that of a restrictive lung disease, what we already saw. We have all the raw material ready. Exactly place it. You'll have a beautiful answer coming in your exam paper. Fine. Then let's go to lung cancer. Lung cancer, I already told the clinical feature. Please look for paraneoplastic syndrome in the question so that you can pinpoint as it's squamous or small cell carcinoma. Mostly small cell carcinoma comes in an exam because SAADH Cushing's I can easily create a 4-5 line clinical scenario. Otherwise, it's going to be elderly, smoking, loss of weight, loss of appetite. SAADH makes it much more interesting. So please look for that and make sure you don't miss it and write a small cell carcinoma, right? And location, central, squamous and small cell carcinoma will be in the central. Periphery will be adenocarcinoma generally, fine? Okay, now let's go to lung cancer, the same template. Etiopathogenesis. With respect to cancer, I need to know the gross, microscopy, immunohistochemistry, and maybe one word about the prognosis or the outcome, right? So risk factors, smoking, pollution, radiation, this idiopathic pulmonary fibrosis, and even occupational lung disease. All these are sporadic risk, and the most important risk is undoubtedly smoking. It's undoubtedly smoking is the most important risk. At the same time, I do also have genetic mutations which play a major role in lung cancers, right? Can anyone tell me which of the lung cancers genetic mutations are more important? Is it important for squamous? Is it important for adeno? Is it important for small cell? We'll talk about it for sure for all of them, but I want you to not to forget for adenocarcinoma, because adenocarcinoma is very, very important when we come to your genetics, right? So genetic mutations for an adenocarcinoma, see, these are not inherited risk factors. These are sporadic risk factors, which means any one of us can be predisposed to. One is EGFR. This is most common in Asians, including Indians. I can have KRAS and ALK. So these are the 3 common genes which are mutated in case of a lung adenocarcinoma, and I want you to remember all 3. If it's difficult, at least don't forget EGFR. EGFR has to be there. Fine. Okay. Thank you, Debita. Fine. Yes, small cell carcinoma is undoubtedly more aggressive, right? Perfect. So if I want to add, see, genetics is not actually as important as a small cell for squamous cell carcinoma and small cell carcinoma. But if you want, you can write on, you can write a little bit of it, right? So squamous cell carcinoma, we do have your P16 mutation, TP53 loss. These are something which are commonly seen in case of a small cell carcinoma, tumor suppressor gene mutations, P16 and your P53. And like Arpit said, small cell carcinoma is something which is most aggressive. If it's a most aggressive cancer, I need to have the most aggressive mutation. What do you think is the most aggressive mutation? It's always our P53. So here, there'll be 2 important guys which will be knocked off, P53 and retinoblastoma. These 2 are less important. Please don't forget ALK, EGFR and KRAS. That's more important with respect to mutations, right? Because these 2 primarily are recurrent smoking related mutations are happening. But this mutation causes the cancer. Here mutation is the outcome of the smoking or radiation or the pollution, fine? So we know about the etiology. Pathogenesis, I'm going to take a little bit into whenever we discuss individually squamous or adeno or your small cell carcinoma, right? So let's go to squamous cell carcinoma. Squamous cell carcinoma, the most important thing is a crude variant of smoke which causes squamous cell carcinoma. You can write this. It's there in Robbins as well. Whenever it's a crude variant of smoke, it settles in the bronchus. In the bronchus, it causes squamous metaplasia. If the person is not going to stop smoking, is going to continue smoking, okay, more smoking, right? It results in mutations. Here is where you can write the mutations of, I can have P16 mutations or TP53 mutation, which can result in squamous dysplasia, which can progress to squamous cell carcinoma, right? It's simple, okay? Crude variant of squamous cell carcinomas can sometimes cause bronchiectasis. It's not a hard and fast rule, it should, but yes, there's a possibility it can cause. That's why if you look at the clinical features of squamous cell carcinoma, I would have put wheezing because it's there in the bronchus, it can, right? Crude variant of smoke is nothing but like a BD. Unfiltered variant of smoke is crude variant of smoke, right? So filtered smoke always increases the risk of adenocarcinoma. This unfiltered smoke increases the risk of squamous cell carcinoma, fine? Clinical feature, we already know, but don't forget this, hypercalcemia. Hypercalcemia is a paraneoplastic syndrome, which I want you to remember. Actually, gross, no? You can draw a diagram. It's very simple to draw diagrams of lungs. Draw bronchus. They are very large lesions, infiltrative lesions, can have cavity, can have necrosis, right? That's how it's going to be in the center. They are hilar lesions or they are central lesions. They have cavities on X-ray because there'll be central necrosis on X-rays, okay? And yes, like Krishan said, it can invade or encroach the bronchus and can sometimes present with hemoptysis, COPD, wheezing, blocking, bronchiectasis also, but not the primary finding. Yes, it can cause, but it's not the primary finding. Hilar lesion, central lesion, cavitation, it's squamous. What is the classical description for any squamous lesion? It's pearly white. It's always the same, right? Wherever you write squamous cell carcinoma, pearly white, cauliflower like, no one can say wrong. Or if you don't want to use the term cauliflower, you want to be more scientific here, right? Exophytic mass. It grows big, right? It's an exophytic mass. That's classical for you. Any squamous cell carcinoma, not for this. Keratin pearl is in microscopy. I'm looking for gross. Pearly white. See, this is the color of squamous, right? Keratin, skin. Palms and soles are very thick keratinized. Same color will be the cancer as well, right? Grossly, right? Microscopy, you're right. Microscopy, like I said, patterns of neoplasia, very important, right? So what I'll see is, I'll see keratin pearl in microscopy. plus I will obviously have 4 feet of dysplasia. Please don't write 4 feet of dysplasia in an exam. In an exam, keratin pearl, invasion of the basement membrane. These are two things to say it's a carcinoma and squamous. High NC ratio, mitosis, atypical mitosis, right? Pleomorphism will be there and there'll be a loss of polarity, fine. What causes fibrosis shrink? Inflammation, right? Inflammation is the reason for cancer and not the end fibrotic, fine. Okay, and IHC. So IHC here, Archana, it's not P67, it is P63 or P40. Both of them are good markers. P40 is a better marker, but it's fine. P63 and P40, not 53. P63 and P40, both of them are classical markers for squamous cell carcinomas, right? This can be something which can be used for any squamous cell carcinoma across the body. Keratin pearl 4 feature dysplasia, 63-40, pearly white exophytic mass or a pearly white cauliflower shaped growth. If you want to draw a microscopy, let's try drawing a keratin pearl. It's not difficult to draw a keratin pearl, no. Cancers can easily be drawn because you need not be beautiful here. It is ugly, right? I can draw a high NC ratio here. I can draw a small cell here with a small nuclei here. If you want, draw a cell with mitotic figure here. It's ugly. It's ugly. That's how it's going to be, right? It will not be the same. Pleomorphism, high NC ratio, but keratin pearl is something which is diagnostic. If you want to draw diagrams, you can easily draw line diagrams. Don't worry about the beauty of the diagram. That's not important here. That's not what you have for. It's descriptive. Neat diagrams is more than enough, right? Let's go to adenocarcinoma. Adenocarcinoma is seen in non-smokers also, because that's something which I'll be looking for upfront itself. It's not something seen only in smokers. It can be seen in non-smokers. It can be seen in women. It can be seen in men. And it's more of a peripheral tumor than in a central tumor, right? So be it smoker or non-smoker. If it's a smoker, I would say a filtered variant of smoke can also cause this. Will reach the alveoli. Will cause mutations in the pneumocytes. A non-smoker related, these are sporadic mutations which can happen in anyone. Okay, but ultimately both are mutations which happens in the terminal, which happens in the alveoli. So obviously it will form a tumor looking like a gland, right? So it increases the risk of carcinoma in the alveoli, which results in adenocarcinoma. Fine. So it's primarily coming from the alveolar epithelium, but shaped like a glandular tumor. So I'm going to call it an adenocarcinoma, right? I do have microscopy. There are 3 differences. I'm not going to write the entire thing, but I'll definitely give you the 3 different types of adenocarcinoma soon. Clinical features same. Gross, they are peripheral tumor. They are single lesions. They are infiltrative lesions. That's very, very important. So if you want to draw a diagram, you can draw a lung. Single. They are very, very unlikely to be multiple. Bilaterality is a little bit common because of the interalveolar spread. Because of the interalveolar spread, I can have bilaterality coming from the one alveoli. It can go. It's like lipidic pattern of spread. It can go to the other lung also. Bilaterally, something is common in case of an adenocarcinoma, right? So I'll write the IHC. I'll look into the microscopy very, very soon. 2 markers, never forget, TTF1, napsin A. Both are the classical markers for a lung adenocarcinoma. This is only for lung adenocarcinoma, not for other adenocarcinomas, fine? So when you come to microscopy, I'll just add one more page here. There are 3 things with respect to lung adenocarcinoma, right? So we have something called an atypical adenomatous hyperplasia. That's the first and the foremost thing. Then we have adenocarcinoma in situ. Then we have invasive adenocarcinoma. Fine. Atypical adenomatous hyperplasia, yes, Rishan. Multiple, always we suspect metastasis. Less than 5 millimeter mass. Microscopy, I'll randomly see few dysplastic cells. Okay. Adenocarcinoma in situ, 5 millimeter to 3 centimeter mass or 3 centimeter lesion. So what I see in microscopy here is, I do see a pattern called as lipidic pattern of growth. It's in situ, so that'll be most important thing, no invasion. You can draw diagrams here beautifully and easily. Again, very descriptive diagrams. Fine. So let's draw for all three of them. Keep the number of alveoli to be minimal. Okay. So here I have all the flat ones. Suddenly I have a dysplastic cell. Everything is normal flat, suddenly a dysplastic cell. Everything normal flat, suddenly a dysplastic cell. Atypical adenomatous hyperplasia. Random few dysplastic cells, right? Here what I'll have is, I'll have dysplastic cell all through the alveoli. That's why it's lipidic pattern of spread. All of them here are ugly. All of them lining the alveoli are ugly. But the most important thing is there's no invasion. It's still within the alveoli. So what tells me it's adenocarcinoma is, I do have dysplastic cells here. I'm not denying that. The only difference here is I'll have the neoplastic cells here also, invasion. Whenever you write invasion, you have to also mention the desmoplastic reaction. So that's a difference, right? It's random, few cells, completely lined by dysplastic cells plus invasion and desmoplasia, right? So to call an invasive adenocarcinoma, I need the, it can be 1 centimeter, 2 centimeter, doesn't matter here. The most important thing for me is glance is the pattern. I'll have the 4 features of dysplasia, elaborate the 4 features of dysplasia. And the most important thing is invasion into the interstitium. And obviously you'll have fibrosis or white right fibrosis, right? Desmoplasia. You'll definitely have desmoplasia. Fine. Okay. So you can show the description, you can show the change. These are very simple diagrams. It will not take much time, right? Need not be beautiful. Few, random, continuous, lipidic, invasion. What I want to convey is only this. You can convey in the form of text or you can convey in the form of simple line diagram. That's more than enough, fine? Okay, that's for the microscopy of adenocarcinoma. So we know about the pathogenesis, bit about the clinical features, and obviously the gross findings and also the microscopy and the IHC here, fine? Let's go to small cell carcinoma. Whenever you write small cell carcinoma, the most important thing is that's the most aggressive variant of cancer. They're the most aggressive variant of lung cancers, right? It's a neuroendocrine tumor, but they are the most aggressive variant of lung cancers. Small cell carcinoma of the lung is almost always associated with smoking. You cannot see a patient with small cell carcinoma lung who's a non-smoker. Okay, it will almost always be with smoking. That's something which is very, very classical for small cell carcinoma of the lung. That's one. So recurrent chronic smoke will induce P53 and RB gene mutation that makes the neuroendocrine cells become neoplastic. If you want to elaborate this in a long answer, you can write what P53 does, what retinoblastoma does, and how it increases proliferation, fine? I'm not understanding your question, sir. Can you please let me know? NEET, zoology NEET. It's a physiology thing. I might lead you wrongly if you are studying for NEET and will not be the right person. What I don't know what NCRT says. Please go with your biology teachers. Fine. Okay. Come back to medicine. We'll teach you for sure. Okay. Clinical features. The paraneoplastic syndrome, which is something which is very important. SAADH and also Cushing's. In addition to the clubbing, in addition to the cough, in addition to the loss of weight, loss of update, these are something which I want you to remember, right? Gross, they are again central lesions. They might be tiny, but they will definitely have necrosis. Necrosis can be easily seen in gross thing because it's a very, very highly aggressive tumor, right? Microscopy, you'll have small round cells. Previously, it was called as oat cells. If you want, write that. If you want to impress your old examiners. Now we don't use term oat cells. They are elongated, so we call it. SCC is squamous cell carcinoma, right? Small cell carcinoma is different. Squamous cell carcinoma is different. Yeah, small cell carcinoma cells are small, round, and blue. That's why we call it small cell carcinomas. Okay, Rishank, it's simple, right? Small cell carcinoma is a bit of a more aggressive tumor, more primitive tumor, like we saw with Wilms tumor. They are like blastemal elements, that's all. That's why they look smaller. So anything blastemal, anything becomes more undifferentiated. It becomes smaller. That's why we call it small cell carcinoma. When I take lung, it's a biopsy. The cells might not be bigger. It will be like uniformly looking like lymphocytes. So we use the term small cell, right? Perfect. Two things what Devyan said. Both of them are required for me. In a low power microscope, I would see azopardy effect. Azopardy effect are like perivascular survival. Okay. Okay, Rishi. So azopardy effect, it's nothing but you'll have condensed DNA surrounding vessels. We see condensed DNA surrounding vessels, that's azopardy effect. And in high power, all of the neuroendocrine tumor will have salt and pepper chromatin. It's a mixture of euchromatin and heterochromatin, which is salt and pepper chromatin, which is true for every neuroendocrine tumor across the board, not just for lung, anywhere across the body, right? So if I want to draw a diagram, in a diagram of small cell carcinoma, please draw the vessels bigger, because if I have to fill the entire page or the entire field with small cells, I have to spend more time, right? So draw bigger vessels, draw more necrotic areas, because they're extremely necrotic tumor, extremely highly proliferated tumors. Most of them will have necrosis, and like I said, it'll have blue condensation surrounding the vessels, right? So that's my azopardy effect. I will have necrosis, and you can draw cells like this. Make sure the cellular component of the image is less, so that you need not keep on putting more and more small round cells here, right? So you have small cells here, necrotic area, and you have the azopardy effect here. Fine. Okay. Got it? Simple diagrams. I just want you to understand what it is. It need not be beautiful. I know that most of you feel that your handwriting is not good. That's the reason you lose mark. That's an excuse. Draw this. No, my handwriting is worse, but still I can draw a descriptive diagram which you can understand. If you draw the same, your examiners can understand. That's it. Fine. IHC, true for every neuroendocrine tumor. Simple things. Synaptophysin, chromogranin. Okay. If you want, write bombesin 56, 57, everything, and these two are at least basic. I can have CD56, CD57. There are many markers. There is NSC, but at least synaptophysin, chromogranin are the basic ones I want you to guys to remember. Fine. So that's about lung cancers. We saw about squamous, we saw about adeno, we saw about your small cell carcinoma as well. Fine. There's a very likely possibility cancers can come in a lung cancer with lung. Please remember and please look for the paraneoplastic syndromes and write it is squamous or small cell rather than just writing lung cancer. It's not wrong. It'll be better if you can tell with the help of clinical scenario, okay, it's small or it's a squamous cell carcinoma. Fine. Let's last come to emphysema. Yes, Sathak, you're right. Amrish, yes. The 4 features of dysplasia is there in every tumor, every cancer. You can write that also here. But since I have already small cells, azopardy effect, and salt and pepper, I didn't write. But yes, 4 features of dysplasia will apply here also. Pleomorphism, high NC ratio, mitosis will be seen here as well. Fine. Okay. Emphysema. Emphysema is a destruction of the alveolar wall. causing airspace enlargement and airflow limitation. Right? Simple words. It's not something which is there in the book. Airflow limitation, chronic obstructive pulmonary disease, airway airspace enlargement, emphysema. The reason is alveolar wall damage. Just make up whatever comes to your mind at that point of time. Simple words, what is emphysema? Etiopathogenesis, the predominant etiology for me is smoke. It could be tobacco, could be any part of smoke. Smoke enters the alveoli, it will activate WBCs. So once it activates WBCs, automatically the WBCs will release elastase like what Sarthak said. And the elastase can definitely destroy the elastin of the parenchyma and the alveolar wall. That makes my alveoli dilated. Right? But I do have a protective mechanism. We have anti-protease. So anti-protease, the protective mechanism. What's the anti-protease? That's your alpha-1 antitrypsin. So when I'll have the pathogenesis or when a patient will have emphysema is simple. So I should be a chronic smoker, chronic chain smoking. So I'm going to overpower the capacity of alpha-1 antitrypsin, or the patients having an alpha-1 antitrypsin deficiency. In these two instances, so elastase will become more and elastin will be destroyed and results in dilated alveoli. That's all. Fine. Superb. Okay. You guys know a lot. The only problem of knowing a lot is how to structure them in an exam. Right? Please remember point wise, like whatever Devan said, all the 4 points, amazing. But if you can just ping on to the protease, anti-protease, that's what I'm primarily looking for. Oxidative damage, all these are oxidative damage only, right? And tobacco smoke and alpha-1 antitrypsin deficiency, right? So here, write the symptoms of COPD, what we discussed in the first. Please write the term pink puffers, because that's something which is required. Okay, fine. Gross here is actually the types. Okay, just a second. Sorry guys. Fine. So gross here is the type of emphysema, right? So there are different types of emphysema. How do you define emphysema? You classify emphysema as centriacinar, panacinar, distillacinar, or paraseptal. There's something called as an irregular emphysema also, which is not required for us, right? Okay, fine. So we have, if you want, draw a normal acini here. That's a normal acini. Based on the site of destruction, I can call them as an central destruction, centriacinar emphysema. Centriacinar emphysema is the most common subtype. Centriacinar emphysema is secondary to smoking, and centriacinar emphysema will be seen most commonly in the upper lobes of the lung. Okay, I do a type where the entire alveoli is gone. We call it an panacinar emphysema. Panacinar emphysema is not that common. It's secondary to alpha-1 antitrypsin deficiency. Okay, right? It's seen mostly in the lower lobes of lung. Mostly there'll be a family history present because it's genetic disease, and also there'll be a liver pathology associated. It's not only lungs, liver also will be damaged. Okay, next is the distal acinar. Okay, I can have distal acinar emphysema, or you can use the term paraseptal emphysema, or you can use the term bullous emphysema. This is also seen in due to smoking only. Since in the distal acinar they cause bullae, the bullae are prone to rupture spontaneously or after trauma. Because of the rupture, the presentation is different. They present as what? How do they present? How do they present? They present as perfect tension pneumothorax. Okay, and that something is an emergency, we have to definitely put an intercostal drainage tube so that the patient can come back to normal, right? Simple thing. Irregular emphysema is a post-mortem finding. See, I can definitely say at some point of time when I'm inhaling lots of pollution, I'm in a very polluted environment for let's say 1 week continuously. That point of time, my alpha 1 antitrypsin will be exhausted in my lung, can damage, not clinically symptomatic. So when I die, when they take my lung outside, there may be few pockets in the lung which will be dilated alveoli, irregular. That's why it's irregular emphysema, not clinically relevant. So I'm not going to talk about that. That's it. Fine. Okay. Perfect. So microscopy, what I see in emphysemas, you will see just dilated air spaces. And the most important thing, no fibrosis. There'll be no fibrosis in case of emphysema, which is very important, right? It's easy to draw emphysema. Put small rounds called normal alveoli, big irregular empty space, call it a dilated alveoli. Don't write anything pink in the center because fibrosis will not be there in case of an emphysema. Fine. Okay. Fine. Okay. Rishi asked us a question. None of us answered the answer. Why do they call them blue bloaters? Right, blue color you guys answered. Bloaters is because of chronic inflammation that sometimes these patients might end up in having a little bit of an edema. Right, that's why they were called as bloaters. They're a bit bigger, right? So chronic inflammation associated you can say it can be secondary to amyloid causing damage to the kidney and might cause an edema, but quite a few patients might have a little bit of pedal edema which could be due to chronic lung damage and secondary to heart also. That's the reason chronic bronchitis were called as blue bloaters. Fine. Okay, so that's all for today. So we know about quite a few things in CVS and RS. What I have not covered is the MI. MI is something which is important. It's just a single table. I want you to go back today after the class and go and read MI, which is important. In lung, I think pneumonia is something which is not covered because pneumonia, you know, lots of things in pneumonia with respect to your microbiology. Please use them. Okay, please use them. And when it's a question asked in pathology, just doesn't mean that you have tried only with respect to pathology. Use the knowledge of microbiology. In pathology, with respect to pneumonia, have your typical, atypical. Typical as a stage of congestion, red appreciation, gray appreciation. That's all. And atypical pneumonia, COVID, interstitial inflammation, pneumonia, dry cough, here wet cough. Fine. Okay. Rishank, you wanted to ask some question with respect to your, I forgot that, skin pathology. Tomorrow class. Wait, I'll see what's the tomorrow class and tell you guys. It's at 6:30. My class only is tomorrow. I'll tell you what it is. 1 second, give me a second. We'll be talking about GIT and liver tomorrow. Fine. Okay. Tomorrow we'll complete your jaundice. Diagnosis of jaundice is something which is not required. It's a clinical diagnosis. I don't think we require typical ATL. I'll talk about liver function test tomorrow for sure. Okay, see, melanoma, why in non-exposed areas? See, I do melanoma in non-exposed areas. First thing is it's very, very, very rare, right? So I do have sites inside the body which also has mucosal epithelium, which also has melanocytes. When I have, let's say, radiation, which is there in the anorectal junction, which is causing a rectal adenocarcinoma. Why can't that radiation affect the melanocytes there? Can it? It can. So when I can have a oral cavity lesion, a squamous cell carcinoma due to tobacco smoke, right, that can also destroy the melanocytes a little bit there as well, right? So it's like any other carcinoma, I can have melanoma in non-sun exposed areas as well, but that is not UV related. That pathogen is a bit different and is pretty rare compared to normal sun exposed melanomas. Fine. That is YouTube feature, Rishi. More you comment, you will have the badges. Useless feature. Listen to the lecture, learn. That's enough. Get the first and second in the university. That badge is more important. Okay, Rishan, neurotization is, see, melanocyte is a cell which came from the neural crest, right? So now melanocytes is attached to my skin, they retain the property of melanocytes. So when they go into intradermal, they have lost the touch with my epidermis. So it's like you are from, I'll just give you an example to understand your decision. I think you said you are from Gujarat, right? Let's say you're from Gujarat, but you are studying in Delhi. So you might not have the Gujarati gang. Will you mingle with more with a Delhiite or a Gujarati in your Delhi college? You'll go with a Gujarati in a Delhi college, right? That's joining the terms. So I have a melanocyte which is ideally stuck to Gujarat with the piers in the epidermis in the basal layer, but when it came down, it came to Delhi, which is dermis. So I don't know whom to join with. In dermis also, I have an embryological remnant which came from neural crest. That is nerve. Nerve is also that origin. So like, okay, I will go with this guy. That's neurotization. That's all. Okay. Amrish, PNS chapter means paraneoplastic syndrome. Peripheral nerves. Peripheral nerves, not much. You might have a schwannoma or neurofibroma max. Fine, Rishan. That's what is called as a neurotization. They go with respect to the nerve fiber, which also is having the same embryological origin. Fine. Okay. Done. See you tomorrow. We'll look into GIT and liver. I'll cover liver function test tomorrow for sure, Rishan. Rishank, dysplastic nevus is like squamous metaplasia and squamous cell carcinoma, squamous dysplasia, squamous cell cancer, right? Like that, mole, benign, dysplastic nevi, melanoma. It's the adenoma carcinoma sequence. In between, we have the dysplastic nevi. That's it.